Imagine for a moment that you feel completely fine, not just okay, not managing, but genuinely, quietly well. You wake up in the morning with decent energy, you sleep through the night, you enjoy your meals, your walks, your conversations, your routines. You are 74 years old, and by every measure that actually matters to you, life is good. Now imagine that a single routine appointment, one you walked into without a single symptom, without a single complaint, without a single reason to worry, changes all of that. Not because something was wrong with you, but because a test found something that then set off a chain of events your body was never prepared to handle. And by the time it was over, the life you had been quietly enjoying looked nothing like it did before. That story is not rare. It is not a worst-case scenario reserved for the unlucky few. It plays out in hospitals and specialists' offices across this country every single week, and the data behind it is something the medical system rarely sits down and explains to you in plain language. What I'm about to share with you today comes from years of studying the medical literature, paying close attention to what the research actually shows when the system runs on autopilot, and asking the question that almost nobody in a 15-minute appointment has time to ask. Is this test actually going to help this specific person, or could it send them down a road they never needed to travel? Before we get into the specifics, I need to give you one idea, one framework, because without it, nothing else I say will land the way it needs to. Think about screening medicine the way it works at 50. You find a problem early, you treat it, and you potentially add 30 healthy years to your life. The math is clean. The investment is absolutely worth it. The logic is airtight. But here is what changes after 70, and this is the part that almost nobody tells you directly. Three things shift in a way that quietly rewrites the entire risk-to-benefit equation. First, many of the conditions that routine screening detects in older adults will never actually harm you. They grow slowly, they cause no symptoms. In many cases, you will outlive them entirely. But the moment they appear on a report, medicine does not have a button that says leave it alone and watch. It has a treatment button, and that button gets pressed. Second, your body's tolerance for intervention changes with age. The surgery that a 55-year-old bounces back from in 2 weeks can mean months of difficult recovery for a 78-year-old, with complications, loss of independence, and consequences that ripple through every part of daily life. Third, and this is the one that keeps me up at night, there is something called the cascade effect. One test finds a small abnormality. That abnormality triggers a follow-up scan. The scan recommends a biopsy. The biopsy leads to a procedure. The procedure causes a complication. And a person who walked into a clinic feeling perfectly healthy is suddenly navigating a medical nightmare that began with a test nobody ever explained could lead there. Keep that picture in your mind as we go through each of these, because it is the thread running through every single one. The first thing I want you to think carefully about is routine colonoscopy after the age of 75. Consider a woman, a retired librarian, 77 years old, who had 2 colonoscopies in her 50s and 60s, both completely clean. No polyps, no family history of colon cancer, no symptoms of any kind. Her new primary care doctor glanced at her chart and said she was due for another one. She did her research. She had concerns, but she did not want to seem difficult or uncooperative, so she agreed. What happened next was not the colonoscopy. She never even made it to the procedure. The prep, the strong liquid you drink the night before to completely clear your bowels, hit her kidneys in a way nobody anticipated. By the next morning, she was confused, dizzy, and barely able to stand. Her daughter rushed her to the emergency room. She was severely dehydrated. Her electrolytes had dropped to levels dangerous enough to put her heart at risk. She spent 4 days in the hospital. She never had the colonoscopy. And the most painful part of that story is this: she never needed it in the first place. The United States Preventive Services Task Force, the gold standard body that sets screening guidelines in this country, officially recommends against routine colonoscopy screening for average-risk adults over the age of 75. The evidence behind that recommendation is not ambiguous. After 75, if you have no symptoms, no family history, and clean previous scopes, the risks begin to clearly outweigh the potential rewards. And those risks are not theoretical. Bowel perforation, a literal tear in your colon, occurs in approximately 1 in every 500 colonoscopies. In a younger adult, that is a manageable surgical complication. In a 77-year-old, it can mean emergency surgery, a colostomy bag, extended hospitalization, and a recovery that permanently changes your quality of life. Meanwhile, the colon cancers most likely to be found in asymptomatic older adults through this kind of screening tend to grow so slowly that in many cases they would never cause problems within a person's remaining lifetime. The discovery creates urgency where none biologically existed, and that urgency, that institutional momentum toward doing something, is exactly what the cascade effect feeds on. Now, I want to be clear. If you have symptoms, blood in your stool, unexplained changes in bowel habits, abdominal pain that is new and persistent, that changes everything. See your doctor immediately. But if you are asymptomatic, over 75, with a clean history, there is a conversation worth having before you schedule that next scope. There are non-invasive stool-based tests that can flag genuine warning signs without any of the procedural risks. Ask about them. The fact that your doctor may not bring them up first is itself a window into how the system operates, and it leads directly into the next thing I need to tell you, which surprised even people who consider themselves well-informed about their health. What I am about to say about cancer screening is one of the most misunderstood areas in all of medicine, and I want to be precise here because the nuance matters enormously. I am not saying never screen for cancer. Cancer screening has saved millions of lives, and it may well save yours. What I am saying is that after 75 aggressive cancer screening in average risk, asymptomatic individuals has a serious and well-documented overdiagnosis problem. And overdiagnosis leads directly to overtreatment. Here is what overdiagnosis means in language that cuts through the clinical fog. Imaging technology today is so extraordinarily sensitive that it can detect cancers that are, in biological terms, barely awake. Tiny, slow-growing tumors that left entirely alone would never spread, never cause a single symptom, and never shorten your life by a single day. You would die with them, not from them. But the moment a radiologist writes the word malignancy on a report, the entire clinical machine turns on. Biopsies get scheduled, specialists get called, treatment decisions get made. All of it moves forward with institutional momentum, regardless of whether the cancer actually poses any real threat to the person sitting in the chair. Think about what that means in practice. A 79-year-old man, sharp and independent, still fishing on weekends, goes in for a routine PSA test. It comes back slightly elevated. A biopsy confirms a low-grade, slow-moving prostate cancer. His urologist recommends radiation therapy. He trusts the recommendation, because of course he does, because his doctor told him he had cancer and offered him a treatment. He goes through it. Within a year, he is dealing with chronic fatigue, significant urinary problems, and a quality of life that has dropped in ways he never expected and never fully recovers from. Stories documented across the medical literature describe men who, looking back, wish someone had sat down with them and explained clearly that their cancer was the kind a man his age would almost certainly have lived alongside quietly for the rest of his life, not died from. That knowledge, had it come earlier, might have changed everything. The same pattern appears in mammography data. Studies published in the New England Journal of Medicine found that a substantial portion of cancers detected through mammography in women over 70 were clinically insignificant, meaning that treating them offered no survival benefit whatsoever, only side effects and the emotional burden of navigating a cancer diagnosis. This is not an argument against medicine. It is an argument for honest, individualized conversation. If you have a family history, genetic markers, or symptoms, screen. If you are average risk with no symptoms, ask your doctor directly and specifically, if we find something, what are the realistic treatment options for someone my age and in my health status, and what would we actually recommend doing? That question alone, I promise you, often changes the entire tone of the conversation. But what comes next is the one that surprises people most, because it involves something that sounds so straightforward, so responsible, so obviously a good idea that almost nobody questions it, until they hear what the research actually says. Routine cardiac stress testing without any symptoms. Your doctor says you are 72, and it makes sense to just make sure your heart is doing okay. You get on a treadmill or receive a medication that temporarily stresses your heart while they monitor the response. It sounds completely benign. It sounds like the kind of proactive medicine you should be grateful for. Here is the part they do not tell you in the room. Cardiac stress tests in people without symptoms have false positive rates that can reach 40% or higher in certain populations. Let that sink in for a moment. Nearly half the time, the test flags an abnormality when your heart is actually functioning perfectly well. But medicine cannot simply shrug at an abnormal finding. That false alarm launches you immediately into the next phase, a cardiac catheterization. And catheterization means threading a thin tube through your blood vessels, typically through your wrist or your groin, directly into your heart. It is not a minor procedure. The risks include bleeding, vessel damage, arrhythmia, and in rare cases, it can trigger the very heart attack or stroke you were originally trying to prevent. Now, here is where it gets even more counterintuitive, and this is the part that stops people cold when they first hear it. If the catheterization finds a partial blockage, which is extremely common in adults over 70, many of whom have absolutely no symptoms, the recommendation may well be a cardiac stent. Multiple landmark clinical trials, including the widely cited ischemia trial, found that stenting in patients with stable coronary artery disease did not reduce heart attacks or extend life compared to medication and lifestyle management alone. Read that again slowly. The stent did not help more than the medication, but it carried all the real procedural risks, and it came with a lifetime of blood thinners that carry their own bleeding complications on top of that. So the journey looks like this. You feel fine, you have a routine test, the test produces a false alarm, the false alarm requires catheterization, the catheterization finds a partial blockage, the blockage gets stented, you go on blood thinners, you need ongoing monitoring, and at the end of all of it, you are statistically no better off than someone who simply took medication and went for a 30-minute walk every day. If you have no chest pain, no unexplained shortness of breath, no dizziness during activity, no reason to think something is wrong, the honest conversation with your doctor is not about ordering a stress test. It is about optimizing the actual modifiable factors: blood pressure, cholesterol, blood sugar, activity level, sleep quality. That is where the real gains are. That is where the evidence consistently points. And yet the next thing I am going to tell you is something that even people who have thought carefully about their medical care have almost never heard before. And the reason they have not heard it is precisely why it is so important. Let us talk about bone density. A DEXA scan detects low bone density, and your doctor prescribes a class of medications called bisphosphonates, drugs you may know by names like alendronate or risdronate. You take them for years, faithfully, because you were told they would protect you, because you understood that osteoporosis is real and falls in older adults are genuinely devastating. And I want to be clear, osteoporosis is real, falls are devastating, and bone health absolutely matters. What I am questioning is not any of that. What I am questioning is the automatic pipeline that too often follows a DEXA scan result in patients over 75, a pipeline where a finding leads directly to a prescription without a full accounting of what the research shows about long-term use of these medications. Here is what often goes unmentioned in that appointment. Long-term bisphosphonate use has been associated with a rare but serious condition called atypical femoral fractures. These are spontaneous stress fractures in the thigh bone, the very bone the medication was prescribed to protect. These fractures are severe. They often require surgery. Additionally, these medications are linked to osteonecrosis of the jaw, which is a painful deterioration of jawbone that is both difficult to diagnose early and very difficult to treat once it develops. Meanwhile, the single most effective intervention for preventing fractures in older adults is not a medication. Studies show that Tai Chi alone reduces fall risk by nearly 50%, removing tripping hazards from the home, installing grab bars in bathrooms and hallways, reviewing medications for side effects that cause dizziness, getting vision checked regularly, ensuring adequate protein and vitamin D in the diet. These interventions reduce fracture risk more meaningfully than any pill, and they carry zero side effects. There are absolutely patients who need bisphosphonate therapy, those who have already experienced fractures, those with very low T-scores, those with specific clinical risk factors that make medication clearly the right call. But a routine DEXA scan leading automatically to long-term medication for an active, healthy 74-year-old who has never broken a bone in her life and walks 3 miles every morning That is a conversation worth having rather than a foregone conclusion. Before agreeing to any medication based on a bone density scan, ask your doctor this specific question. Can we review my actual fall risk factors together? And what is the real fracture risk reduction from this medication compared to a structured fall prevention program? The answer to that question may genuinely surprise you, but I have saved the most important one for last. This is the one almost nobody is talking about. And based on what the research shows, it may be the most quietly consequential of all. Asymptomatic carotid artery ultrasound screening. The carotid arteries are the large blood vessels in your neck that carry blood directly to your brain. The logic of screening them sounds simple and entirely sensible. If we find a significant blockage, we can surgically clean it out and reduce your stroke risk before something bad happens. It is proactive. It is preventive. It is exactly the kind of medicine that feels responsible and forward-thinking. And the reality is far more complicated and, for people with no symptoms, far more dangerous than it sounds. Here is the key fact that changes everything. The surgical procedure used to treat a carotid blockage, called a carotid endarterectomy, carries a 2 to 3% risk of causing a stroke during or immediately after the procedure itself. In older adults, particularly those with other health conditions, that risk climbs higher. The United States Preventive Services Task Force explicitly recommends against routine carotid artery screening in adults who have no symptoms, no mini strokes, no episodes of sudden vision loss, no neurological symptoms of any kind. Their analysis of the evidence found that in asymptomatic people, the risk of harm from the surgical intervention outweighs the potential benefit. Here is why that conclusion makes sense when you understand the biology. Many people over 70 have some degree of narrowing in their carotid arteries. That narrowing has often been present for years or even decades, stable, silent, not causing any problems at all. When you screen for it routinely, you find it. And then a well-meaning, genuinely concerned surgeon recommends fixing it. But the surgery to fix a blockage that was never causing symptoms can and sometimes does dislodge a tiny fragment of plaque that travels directly to the brain. The medical literature documents people walking into a routine screening appointment and leaving on a completely different trajectory than anything they had imagined, not because of the blockage that was discovered, but because of the intervention that followed the discovery. If you have no symptoms of stroke or TIA, no sudden vision changes, no facial drooping, no arm weakness, no sudden severe headache, then routine carotid ultrasound is a test that the evidence does not support. The far more valuable investment is in the modifiable risk factors that actually drive stroke risk. High blood pressure, which is the single most powerful stroke driver there is, blood sugar, smoking, atrial fibrillation management, and consistent physical activity. If you do experience any neurological symptom, even a brief one that resolves quickly, get evaluated immediately. That changes the picture entirely. But absent symptoms, this is one of those situations where the kindest, most evidence-based thing medicine can do is not order the test at all. Now, I want to give you something concrete, something you can walk into your next appointment holding, because everything I have described today is only useful if it changes what actually happens in that room. There are 5 questions that can completely transform the dynamic of any medical appointment where a screening test is being recommended. The first is, what is the false positive rate of this test in people my age? That question forces the conversation toward the reality that a positive result may not mean what it initially appears to mean. And it opens the door to discussing whether the follow-up procedures that result from a false positive carry risks of their own. The second question is, if this test finds something, what are the realistic treatment options for someone my age and in my current health status? This moves the conversation away from findings and toward outcomes, because a finding is only meaningful in relation to what you would actually do about it. The third question is one most people never think to ask, and it is perhaps the most important of all. What is the procedural risk of any treatment we would likely pursue? Every procedure carries risk. You have the right to know that risk clearly and specifically before you agree to the test that might lead to it. The fourth question is, what happens if we monitor this instead of treating it immediately? For a substantial number of conditions found in older adults through routine screening, watchful waiting with regular monitoring is not only a legitimate option, it is often the superior one. Asking about it is not being difficult or non-compliant. It is being an informed participant in your own care. And the fifth question is, what is the most effective non-invasive intervention for this condition? Because as we have seen with bone health, heart health, and stroke prevention, lifestyle modifications and appropriate medication management frequently outperform procedural intervention while carrying a fraction of the risk. Any physician who takes their responsibility seriously will welcome these questions. They will respect you more for asking them. They will see you as someone who understands that medicine is not a series of automatic steps, but a set of decisions that require context, evidence, and individualized judgment. And if your doctor dismisses these questions or makes you feel like you are being unreasonably difficult for raising them, that is itself meaningful information about whether the relationship is truly serving your health. What all of this points toward is something deeper than any individual test or procedure. There is a difference between medicine that finds things and medicine that helps you live well. After 70, the goal of your healthcare should not be to generate findings. It should not be to run every available test because the technology exists and the appointment slot is open. The goal should be to protect and extend your quality of life, your independence, your energy, your ability to do the things that actually matter to you on a Tuesday afternoon. The best physicians are the ones who understand that doing less sometimes requires more wisdom than doing more, that recommending watchful waiting demands more courage and more knowledge than ordering another scan. That saying, "I do not think this test is right for you at this point in your life," is one of the hardest and most valuable things a doctor can say, and one of the rarest. You have the right to know what a test is looking for. You have the right to know what happens if something is found, what the realistic treatment path looks like, and whether that treatment would genuinely improve your life or simply create a new set of problems in place of one that may never have become a problem at all. Medicine has given us extraordinary tools, tools that have extended lives, reduced suffering, and created possibilities that would have seemed impossible a generation ago. But tools are only beneficial when they are used in the right context, at the right time, for the right person, with a full and honest accounting of both the potential benefits and the very real risks. You are that person, and you deserve a healthcare experience built around your goals, your values, your body, and your life, not around a checklist that does not know your name. The next time you sit in an examination room and your doctor says, "Let us just run a few tests to be safe," I want you to remember every word of what you have heard today. Not to become afraid of medicine, not to refuse care that could genuinely help you, but to walk into that room as a fully informed participant, armed with the right questions, understanding the longevity lens, and knowing that the evidence is on your side when you ask for a real conversation instead of an automatic referral. Because the life you are quietly enjoying right now, the sleep, the energy, the things you love, that life is worth protecting. And sometimes the most powerful act of protection is knowing when to say, "Tell me more before we begin."